Good evening, everyone, and welcome to today's session. Geeta and everybody. Geeta, am I audible?
Yes, sir.
Yes. Geeta, I'll be starting the session in another 5 minutes. Yeah. So, all right. So, good evening, everyone, and once more, welcome to the wonderful evening. Divya, Sneha, Josna, Geeta, Bharat, and everybody. Every day evening, 6 o'clock, 6 to 7 p.m., we have this session. The whole idea is only audio. Close your eyes and learn the subject. We pick up around 100 points. We do a quick revision. We ask them as the questions and answers between each other. And that is how we become stronger in our preparation, get motivated. Go back to the Incus Learning app, because in Incus Learning app, you have everything. 5,000 video lectures. You are having 1 lakh PowerPoint slides of notes, 70,000 flashcards for you to do revision, 70,000 MCQs as 350 quiz tournaments in the form of 350 quiz tournaments you have. So, sorry, 3,500 quiz tournaments. You can do all the required practice on the Incus Learning app. But still, why these evening interactive sessions? To listen a video, to read a book, it's a boring job. Unless we all meet, we all discuss, we all stimulate each other, that is how the preparation should go on. So let us make the great beginning, Doctor, today. Let us start with a bit of endocrinology. Initially, I'll tell you 5 to 6 points. After that, once more, I will ask them as a random questions. That's how we prepare. Now, in every entrance exam, NEET PG exam, out of 200 questions, 1 question definitely comes from the hormones. Everything, anything about the hormones, you have to be 100% sure for the tomorrow's NEET PG. Now, Doctor, I'd like to ask you, the anterior pituitary typically produces 5 important hormones, in fact, 7 important hormones: FSH, LH, ACTH, TSH, Prolactin, growth hormone, and beta endorphin. Now, from where is this anterior pituitary is derived from? Embryologically, one of the favorite MCQs. It is derived from the oral ectoderm. It's called Rathke's pouch. Now, out of these anterior pituitary hormones, 4 hormones have a common subunit. That is, their alpha subunit is common. What are those 4 hormones? TSH, LH, FSH, and HCG. For this, their alpha subunit is common. So then, if TSH is different from LH, how is it different? It is the beta subunit that determines the hormone specificity and differentiates TSH from LH, FSH, or anybody. Otherwise, TSH, LH, FSH, HCG, for all these 4 hormones, alpha subunits are same, is what you need to remember. Now, there is something called pro-opiomelanocortin, POMC. What is it? A common origin for? From the pro-opiomelanocortin, 3 things are formed: beta endorphin, ACTH, and MSH, melanocyte stimulating hormone. So any condition that makes ACTH to increase will also cause an increase of MSH also. Because both ACTH and MSH का अम्मा जान एक ही है, वो है pro-opiomelanocortin. That is the reason. Can you tell me one condition where ACTH is elevated? Addison's disease. Addison is autoimmune destruction of adrenal, and that leads to decreased cortisol production, that stimulates increased ACTH production. Every time ACTH is elevated, melanocyte stimulating hormone is also elevated, and that is the reason the Addison's patients are typically dark in color, highly pigmented, because every time in addition SDH is overproduced by the pituitary because of the low cortisol due to adrenal destruction. There is a concomitant production of the melanocyte stimulating hormone is what you need to remember. Now, what are the cells which are called basophils in pituitary? What are the acidophils? FSH, LH, ACTH, TSH. Remember, flat. FSH, LH, ACTH, TSH. These four are derived from basophils. Prolactin, growth hormone. They are derived from acidophils. So this is what you have to basically remember, what are derived from basophils and acidophils. Can you tell me what are the four hormones produced by basophils? Once more, come on.
FSH, LH, ACTH, TSH.
Beautiful. And what are derived from acidophils?
Prolactin.
Prolactin and growth hormone. Beautiful. Now, if you look at the adrenal cortex is derived from mesoderm. Adrenal medulla is derived from neural crest. That is what you need to remember. Adrenal cortex has a zona glomerulosa, zona fasciculata, zona reticulosa. From the glomerulosa, angiotensin II, mineralocorticoids, aldosterone, they're all derived from zona glomerulosa. Whereas zona fasciculata, it produces typically glucocorticoids, cortisol. So they're all produced from zona fasciculata. Fasciculata produce glucocorticoids, glomerulosa produce mineralocorticoids. Then zona reticularis produce androgens. And the primary adrenal androgen produced is dihydroepiandrosterone. DHEA is the primary androgen produced by the adrenal. Even testosterone is an androgen, but testosterone is the primary androgen from the testis. But adrenal androgen primarily is dihydroepiandrosterone is what you need to remember. Now, let us talk about endocrine pancreas. All of you know, alpha cells produce glucagon, beta cells produce insulin, and the epsilon delta cells, they produce somatostatin. All of you know very well that important fact. Now let us quickly take around 10 common hormones and 1-2 points about each of them. First is ADH. Which part of the kidney ADH acts and increase the water permeability? Can anybody tell me? Kidney nephron has so many parts, right? Proximal, distal communal tubule, ascending limb of loop of Henle, etc. Which part ADH act to increase the water permeability? Anybody? Anybody? Geeta, are you there? Come on, make a guess, right or wrong. Which part of the nephron ADH acts?
DCT and collecting duct.
Super. It's the DCT collecting duct where there is an increased water permeability by the ADH is what you need to remember. Now, what is a strong stimulant that makes ADH production to happen? Anybody? What is a strong stimulant? Is it the plasma volume, plasma osmolarity, urine volume, urine osmolarity, serum sodium? What is the most important determining factor that strongly stimulates ADH production? Anybody? Come on, feel free to answer. Yeah.
During volume.
Plasma osmolarity. That's good. That's good. That's good. See, what happens now? When we study, we forget. But when we debate, when I ask questions, then you will get that stimulation to remember longer. That is the whole purpose of all friends meeting together and studying together every day. Now, dopamine. What is its effect on prolactin and TSH production? Dopamine decreases the prolactin and TSH. So, dopamine is also called prolactin inhibiting factor. Now, what is the action of antipsychotics, doctor? Are antipsychotics are dopamine agonists or antagonists? Who is going to give me the correct answer? Come on, guess. Guess.
Antagonists.
Very good. So, all antipsychotics are dopamine antagonists. If the dopamine normally decreases prolactin, if dopamine antagonist is acting, what will happen? Prolactin will increase and hyperprolactinemia occur, and that lead to galactoria as the presenting feature whenever you are giving dopamine antagonist, because dopamine decreases prolactin and TSH levels is what you need to emphatically remember. Now, growth hormone releasing hormone. So, what does it do? It increases the growth hormone. So, in this context, you should know one important analog of the growth hormone releasing hormone. That analog is called tesamorelin. 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 Tesamorelin is a growth hormone releasing hormone analog. Where do we use this drug? We use this drug in HIV-associated lipodystrophy. In HIV patients, there is a lipodystrophy. In the nape of their neck, they get a bump of fat. On the front of their face, the facial fat is gone. So to treat that, we use GHRH analog called as tesamorelin is what you have to emphatically remember. Then gonadotropic releasing hormone. So what does it do? Gonadotropic releasing hormone increases FSH and LH. And one point you need to remember is hyperprolactinemia. Hyperprolactinemia typically can suppress gonadotropin releasing hormone. So that is the reason those who have hyperprolactinemia, what will they develop? Hyperprolactinemia suppresses gonadotropin releasing hormone. If there is no GnRH, there is no FSH-LH. If there is no FSH-LH, that lead to amenorrhea, anovulation. That is the reason patients who are having prolactinoma, how do they present? Prolactinoma patients have hyperprolactinemia. Hyperprolactinemia suppresses gonadotropin releasing hormone. Suppressed gonadotropin releasing hormone causes decreased FSH-LH, and that is the reason they typically develop amenorrhea as a presenting feature is what you need to remember. And typically amenorrhea, if it is there, a woman obviously consults her gynecologist, and her gynecologist evaluates how is her prolactin level. That is the reason prolactinomas are very early detected in women, because in women they lead to amenorrhea. So they go to doctor, and the doctor will discover high prolactin. That's how women prolactinomas lot of times are all microadenomas, whereas men's prolactinomas are all larger prolactinomas, macroadenomas. That is what you need to basically remember. Now, suppose if you give tonic GnRH analog, tonically you have administered, continuously administered. First tell me one GnRH analog which is used for continuous tonic administration, loperamide. So if you happen to give loperamide, which is a GnRH analog, tonically for a long period of time, that will have a suppressing effect on GnRH. Whereas if you give pulsatile GnRH, then that will have a stimulant effect on FSHLH. So that is the reason, if you want to stimulate FSHLH, especially in the people who have a delayed puberty, or if they are having anovulation with infertility, then you need to increase their FSH levels, LH levels. For that, you give pulsatile GnRH is what you need to remember. Now, somebody tell me, what is the growth hormone releasing hormone analog called? Come on, quickly.
Tesmorelin.
Yeah, Geeta.
Tesmorelin.
Tesamorelin. Where do you use tesamorelin, Geeta?
In HIV associated lipodystrophy.
Super, super. And what is that GnRH analog?
Leuprolide.
Leuprolide. Beautiful, beautiful. Now comes oxytocin. Oxytocin. Oxytocin causes contractions during labor, all of you know. And also contraction of labor. Not only that, oxytocin also, whenever somebody is suckling the mother's nipple, that will let down the milk. That's called milk let down reflex. Is also because of oxytocin. And oxytocin also modulates fear, anxiety, social bonding, mood, depression. So in the postpartum period, all these oxytocin effects will cause a lot of things in the woman. Fear, anxiety, social bonding, mood, depression, everything, oxytocin. Then prolactin. Prolactin stimulates the production of milk. Please remember, production of milk is called lactogenesis. Release of milk is called milk let down reflex. A lot of students confuse between the two. Oxytocin is for milk let down reflex. Prolactin is for lactogenesis. Prolactin decreases, even prolactin also decreases gonadotropin releasing hormone. That is what you need to basically remember. So gonadotropin releasing hormone, it is suppressed by the hyperprolactinemia. So that's the point you need to remember. So prolactin is increased in prolactinoma. Already we discussed. When there is a prolactinoma, they present with prolactin suppresses FSHLH. Hence they present with amenorrhea, osteoporosis, hypogonadism, galactorrhea, etc., etc. Similarly, during breastfeeding, what will happen? In a breastfeeding mother, why there is amenorrhea? Because breastfeeding increases prolactin. Increases prolactin, decreases the gonadotropin releasing hormone. Decreased gonadotropin releasing hormone decreases FSH and LH, and that causes delayed postpartum ovulation. After the delivery, ovulation, anovulation occurs because of the high prolactin levels. Next comes somatostatin. Tell me, what is the effect of somatostatin on growth hormone and TSH production? Anybody? Effect of growth hormone, somatostatin on growth hormone and TSH production.
Decreases.
Very good. Decrease GH, decrease TSH. That is the reason somatostatin is also called growth hormone inhibiting hormone, is what you need to remember. And somatostatin analogs are typically used to treat acromegaly because it inhibits the growth hormone. Next comes TRH. TRH rises TSH. Everybody knows that. But what is the other hormone other than TSH that TRH will cause a stimulation and increases? Can anybody guess? What is the other hormone which increases whenever TRH is increased? Can anybody tell me? Guess. Geeta, Divya, Mati, Samir, Sneha.
Gonadotropins. Gonadotropins.
Gonadotropins. Notch. Anything? Anybody else? Anything else? Okay, I'll give a clue. High TRH lead to galactoria. Now tell me. High TRH lead to galactoria. That means TRH increases which other hormone other than TSH?
Prolactin.
Prolactin.
Beautiful. So when we all meet, when we all discuss together, you will remember for long. So what you need to do is, after this session is over, you need to quiz your classmates. So that is the story of TRH. Now quickly, can anybody tell me what are the basophil produced hormones, acidophil produced hormones? Basophil produces 4 hormones in the pituitary. What are they? Come on, doctor. Very good. FSH, LH, ACTH. अभी पढ़ा ना डॉक्टर, flat. T for TSH. Good. You should keep on revising, playing with your classmates after you go back to the reading room, right? Then it will be very effective. Now let us talk about growth hormone. 5 to 6 points about it. Growth hormone is called somatotropin. Growth hormone is produced by anterior pituitary. Growth hormone stimulates linear growth. It stimulates muscle mass. How will it do? It will do through a hormone called insulin-like growth factor 1. Insulin-like growth factor 1 is also called somatomedin C, is what you need to remember. So, who produces insulin-like growth factor 1, otherwise called somatomedin? Liver produces. So, growth hormone stimulates linear growth and muscle mass with the help of IGF-1, which is produced by liver. Growth hormone is anti-insulin. That's the reason high growth hormone will lead to diabetes. Growth hormone typically is released whenever GHRH is stimulates it. Now, one of the favorite MCQs in the exam is, what are the stimulants? What are the inhibitors of the growth hormone production? So, exercise, deep sleep, puberty, hyperglycemia. All these 4 increase growth hormone secretion. Then what are inhibitors? Glucose, somatostatin, somatomedin, they're all inhibitors of growth hormone. That's what you need to remember. So how do you treat excess growth hormone? we typically give somatostatin analogs like octreotide, or you will do surgery. Now, quickly, somebody tell me what lead to increased growth hormone, decreased growth hormone, Dr. Laurekbar, go now.
Deep sleep, exercise.
Very good. Increased secretion is caused by deep sleep, exercise. Gita,
Hypoglycemia.
very good. Hypoglycemia. Then fourth factor, puberty. Similarly, secretion is decreased by Divya, Mati, anybody can answer. Yeah.
Somatostatin, somatomedin, and glucose.
Super, super, excellent, excellent. Now next comes the antidiuretic hormone. At least 5 to 6 points about antidiuretic hormone. You ought to be 100% sure of it. Antidiuretic hormone को कहते हैं vasopressin. Vasopressin. And antidiuretic hormone is synthesized not in pituitary. It is synthesized in hypothalamus. Supraoptic nucleus, paraventricular nucleus in the hypothalamus produce antidiuretic hormone. And antidiuretic hormone is stored in posterior pituitary. So what is the function of antidiuretic hormone? There are two kinds of receptors for ADH. One is called V1 receptor, other is V2 receptor. So ADH regulates our blood pressure because antidiuretic hormone is a strong vasoconstrictor. It leads to rise of BP. So it is the V1 receptors on which ADH act to regulate blood pressure. And ADH acts on V2 receptors and regulates serum osmolality. So the primary function of the ADH is basically serum osmolality regulation. So whenever ADH is there, there is an antidiuresis. All the water is retained in the body, that decreases the serum osmolality, increases the urine osmolality. Urine becomes concentrated. And how is water reabsorbed more if the ADH is there? There is an aquaporin channel. Aquaporin channel, they become more and more created in the principal cells of the renal collecting duct. That is where ADH acts, increases the aquaporin channels, and that leads to development of water reabsorption, and that decreases the serum osmolarity and increases the urine osmolarity, and it is these V2 receptors on which the ADH act and alter the serum osmolarity is what you need to remember. Now, what is central diabetes insipidus? ADH production is decreased. So ADH levels are low. Whereas nephrogenic diabetes insipidus, ADH is there, but it is unable to cause that aquaporin channel insertion on the principal cells of the renal collecting duct. So that is the reason ADH is high in nephrogenic diabetes insipidus, because it is target end organ receptor level resistance, whereas ADH levels are low in central diabetes insipidus is what you need to remember. And nephrogenic diabetes insipidus, what is the reason? Why the resistance? Because there is a mutation in the V2 receptor. So if there's a central diabetes insipidus, what is the drug you want to use? You can still use an analog of ADH. So desmopressin is the analog of the ADH, which is used in central diabetes insipidus. What is the other condition where it is used? desmopressin. There is also an entity called nocturnal enuresis in children. Normally until third year it's okay, but beyond it you need to evaluate, and if you want to treat nocturnal enuresis, bedwetting, and want to decrease the urine output in the night, we use desmopressin, which is the ADH analog, is what you need to basically remember. So that is the story of ADH. Now quickly tell me, mere pyare Bharatwasiyon, nephrogenic diabetes insipidus is because of resistance mutation of which receptor?
B2 receptor.
Beautiful, beautiful, beautiful. Then what is the analog of somatostatin you use in treating growth hormone excess?
Octreotide.
Beautiful, beautiful, beautiful. Now, what is the secondary mediator of the growth hormone? How growth hormones stimulate linear growth?
Insulin-like growth factor.
Insulin-like growth factor 1. And who produces that?
Liver.
Liver. Beautiful, beautiful, beautiful. Then, which hormone is called a growth hormone inhibiting hormone?
Somatostatin.
Wonderful. And which hormone modulates fear, anxiety, social bonding, mood, and depression?
Oxytocin.
Excellent. What is that analog of GHRH used in HIV? Tesamorelin. Right? Tesamorelin. In life, you will use the tesamorelin or not, we don't know. Unless you become an endocrinologist. But to pass NEET PG exam, tesamorelin, 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 you have to keep on playing that rock music until you get the seat. All right. We all played the rock music and reach at this point after, no worries. Now, the next part of the story is prolactin. 10 points. Let us know about it. Prolactin is structurally homologous to growth hormone. Prolactin. Excess prolactin high prolactin will decrease FSH and that decreases the libido. And any agonist of dopamine inhibit the prolactin. Can you tell me one dopamine agonistic drug? Can anybody tell me what is a dopamine agonistic drug that is used in treating prolactinoma, that inhibits the prolactin secretion? Come on, anybody?
Bromocriptine.
Beautiful, wonderful. Bromocriptine. And most antipsychotics, they're all dopamine antagonists. Metoclopramide, dopamine antagonist. Similarly, estrogen, which is there in the OCPs, pregnant women have high estrogen, they all stimulate prolactin. That is what you need to remember. Then TRH, that is thyrotropin releasing hormone, increases the prolactin secretion. So typically in primary and secondary hypothyroidism, there is a high TRH, and that increased TRH increases the prolactin secretion is what you have to basically remember. That's the reason hypothyroid individuals present with amenorrhea and ovulation. Why? Because high TRH also has an effect of causing inhibition of the, has the effect on increasing the prolactin secretion. High prolactin secretion is what you need to basically remember. Now, let us quickly talk about thyroid hormones. So basically, all of us read in our MBBS first year physiology If at all one hormone we know very well means that will be thyroid. So thyroxine is produced in the thyroid follicles. There is this enzyme called 5-deiodinase that convert T4 into T3 in the peripheral tissue. And this peripheral conversion of T4 to T3, what are the things that inhibit T4 to T3 conversion? Beta blockers, propylthiouracil, glucocorticoids, they're all known to lead to decreased T4 to T3 conversion is what you need to remember. Reverse T3 is a metabolically inactive byproduct. And it is produced by the peripheral conversion of T4. From T4, T3 can form, reverse T3 can form. So, the growth hormone, whenever it is excessive, whenever glucocorticoids are excessive, they will cause more and more amount of T4 to convert into metabolically inactive reverse T3, and that is the reason they lead to hypothyroid state, is what you have to remember. So 5-deiodinase, a lot of people have a confusion on the different enzymes in thyroid production. 5-deiodinase converts T4 to T3 is what you need to remember. Then there is a thyroid peroxidase. What will it do? Oxidation, organification of iodine, coupling of monoiodotyrosine and diiodotyrosine. They are all the functions of thyroid peroxidase. So basically, if thyroid peroxidase is inhibited, you can decrease the production of the thyroxine. So how does propylthiouracil methimazole act? Methimazole and propylthiouracil inhibit thyroid peroxidase. That is what you need to remember. Now, what is meant by Wolff-Chaikov's effect? If you suddenly expose a person to excess iodine, it will temporarily turn off the thyroid peroxidase, and that decreases T3, T4 production, which is called Wolff-Chaikov. Geeta, what is Wolff-Chaikov effect?
When patient is suddenly exposed to excess of iodine, there is temporary inhibition of thyroid peroxidase, therefore he lands up in hypothyroidism.
Very good. And what is the enzyme involved in the peripheral conversion of T4 to T3?
5-deiodinase.
5-deiodinase. Excellent. Tell me 3 drugs that inhibit the peripheral conversion.
Beta blockers, propylthiouracil, glucocorticoids.
Very good. Beta blockers, propylthiouracil, and glucocorticoids, you should remember. Excellent. Now, what are the functions of thyroxine, especially T3? One easy way to remember is, remember 7 B's. B for Bhagyalakshmi, B for B, right? B, A, B, B. Number 1, thyroxine causes brain maturation. So 1B is brain maturation. That's the reason whenever hypothyroidism is there, that leads to mental retardation in the newborn. So brain maturation. Thyroxine lead to the bone growth. B for bone growth. They be synergistic with growth hormone. Thyroxine has beta adrenergic effects. It will increase beta 1 receptors in the heart. So increased cardiac output, increased heart rate, increased stroke volume, increased contractility, etc. A lot of times when patients of hypothyroidism come to us, we will try to aggressively start them on 50 micrograms, 75 micrograms, 100 micrograms of the thyroxine. But always be careful. Always be careful. Because thyroxine increased cardiac output, heart rate, stroke volume, and increased BP. You may be aggressively treating hypothyroidism, but that can lead to a sudden shooting of heart rate, stroke volume, blood pressure. Some people may go even into atrial fibrillation, palpitations, etc. So whenever thyroid toxicosis is there, we give beta blockers in order to decrease the adrenergic symptoms of thyroid toxicosis, because thyroxine causes beta adrenergic effects by increasing the beta 1 receptors is what you need to remember. The next B. Thyroxine increases basal metabolic rate. How does it do? It will increase sodium potassium ATPase levels. That will increase the oxygen consumption, increase respiratory rate, increase body temperature. That is how thyroxine will function. Thyroxine acts on blood sugar. B for blood sugar, because it increases glycogenolysis and gluconeogenesis. Both of them will increase the blood sugar. Pyroxene increases breakdown of the lipids. That means lipolysis. Similarly, thyroxine stimulates the surfactant synthesis in babies. So, any low thyroxine will lead to hyaline membrane disease in the newborn, because it stimulates surfactant synthesis in babies, is what you need to remember. Can anybody tell what are the 7 B's about thyroid hormone? Come on, doctor. B for
brain
good.
growth, maturation, bone beta energetic effect, blood pressure, blood sugar, body temperature.
Correct. So basal metabolic rate is increased. What is the effect of thyroxine on glycogenolysis and gluconeogenesis?
Increases.
Very good. Then what is the effect of on lipogenesis and lipolysis?
Breakdown of the lipids.
It increases lipolysis. And what is the effect on surfactant synthesis?
Increases.
Increases. So brain maturation, bone growth, beta 1 receptors, basal metabolic rate, blood sugar, breakdown of lipids, and surfactant synthesis in babies. That is what you need to remember. Now, how is thyroxine production regulated? Thyrotropin releasing hormone increases. Thyroid stimulating hormone release that acts on follicular cells and that increases thyroid production. Then, what happens in Graves' disease? Why the patients have hyperthyroidism? Because in Graves, there are immunoglobulins which are called thyroid stimulating immunoglobulins. They increase the thyroxine production in the follicular cells. That is the reason Graves is a hyperthyroid condition. Now, what is the effect of free T3, free T4, negative feedback on pituitary hypothalamus? Whenever free T3, free T4 is high, as in hyperthyroidism, they go back, tell the antipituitary and decrease TRX production. decrease TRH sensitivity, and they act on hypothalamus and decrease the TRH secretion. So secretion of TRH is decreased in hypothalamus, and sensitivity to TRH is decreased in anterior pituitary. That's what you need to remember. Now, you need to know about thyroxine binding globulin, TBG. TBG binds with T3, T4. Anything, if you are bound, means you become inactive. Binding is like getting married, otherwise you are a bachelor. A bound T3, bound T4, inactive. So tell me conditions that increase TBG and decrease TBG. Very important question. TBG is increased in pregnancy. TBG increases with the use of oral contraceptive pill containing estrogen. That is the reason those who receive OCP, those who are pregnant, their TBG levels are high, and that increases the bound form of T3, T4, and total T3, T4 levels will increase. So what causes decrease of TBG? Steroid use, nephrotic syndrome, they typically decrease the TBG is what you need to remember. Can anybody tell me why Graves is hyperthyroid? Geeta Bede, what is your answer?
Thyroid stimulating immunoglobulin will stimulate the follicular cells, therefore there is excess of thyroxine production.
Beautiful. Tell me the factors that increase TBG.
Pregnancy,
Pregnancy, OCP, and TCP.
Very good. Decrease TBG.
Steroid and protection.
Beautiful. Steroid use and nephrotic syndrome is what you need to remember. So that is all the story, doctor, about thyroxine. Then we are left with a little bit on Parathyron. Do you guys still have energy?
yes sir.
Okay, good, good. So every day 6 to 7, I become your classmate. I will sit with you. I will pick up the white chalk piece and slate and start writing. A, amma, B, ball, like that, right? And I thank you all for joining this class because of you, I get a chance to become a first year MBBS student once more. And the real way we remember is when we look at PowerPoints, videos, and all that, we forget, they're all deviation. You lend your ears, only you are listening, close the eyes, listen, and reproduce. That's the only way you become champions. Now, let us talk about Parathyron. Parathyron increases the free calcium in the blood. One of the favorite questions. Then, what is the effect of Parathyron on the gastrointestinal system? It increases calcium absorption from the GIT and phosphate absorption from GIT. What is the effect of Parathyron on the bone? It causes the resorption of the bone. Because of that, it increases the calcium, increases the phosphate. What is the effect of Parathyron on the kidney? Parathyron acts on the distal convoluted tubule and increases the reabsorption of the calcium from the distal convoluted tubule. And Parathyron acts on the proximal convoluted tubule and decreases the phosphate reabsorption. Please remember that. Phosphate reabsorption in kidney is reversed to its effect on bone and GIT. All right. So it decreases phosphate reabsorption in proximal convoluted tubule. So phosphaturia will occur whenever Parathyron is extra. Then parathyron increases the 125 dihydroxy vitamin D3 calcitriol production. How? It acts on proximal convoluted tubule, increases and activates 1-alpha hydroxylase in PCT, and that is how it increases the 125 dihydroxy vitamin D3. That is what you need to remember. So parathyron increases, ultimately what is the effect of it? Parathyron ultimately increases the serum calcium, decreases serum phosphate, increases urinary phosphate, and increases the urinary cyclic AMP is what you need to remember. Now, there are some receptors which are called rank L receptors. That is receptor activator of NF-kB ligand. NF-kB ligand, receptor activator of NF-kB ligand. That is called rank L. So this rank L is secreted by the osteoblasts and osteocytes. So this rank L secretion by osteoblasts and osteocytes is increased by your parathyron. Parathyron even binds to the rank receptor on osteoclasts and their precursors, osteoclast precursors, and it stimulates the osteoclast and lead to bone resorption and increases the calcium, serum calcium. So that is how parathyron effects on the bone to increase the resorption is all because of its action on the rank receptor on the osteoclast, and also it increases the rank L receptor on the osteoblasts and osteocytes. So once more, be very clear. Rank L is there on osteoblasts, rank is there on osteoclasts. So if you happen to give intermittently parathyron, it will act mainly on rank L. So it will cause more amount of bone formation, right? Whereas continuous administration of parathyron, it will act on osteoclasts and stimulate rank receptor and causes bone resorption. That's what you need to remember. So that is the reason parathyron, PTH, you can also remember. P for phosphate, P for parathyron, and T is, what is the effect of parathyron phosphate? Phosphate decrease in serum. That's the reason parathyron, PTH, you can remember, phosphate trashing hormone. It decreases the phosphate levels. That way you can remember. Now, there is a parathyron related peptide. It functions similar to parathyron. So typically this parathyron related peptide is increased in squamous cell carcinoma of the lung, renal cell carcinoma, and because of its rise, there is a bone resorption. It is not exactly parathyron, but parathyron related peptide increase in the squamous cell carcinoma of the lung lead to bone resorption in malignancy is what you need to remember. Now, how is parathyron regulated? Any fall of serum calcium increases parathyron secretion. Any rise of serum phosphate lead to increased parathyron secretion. Any fall of magnesium lead to increased parathyron secretion. Any fall, severe fall, normal fall of serum magnesium, PTH secretion increases. But very severe hypomagnesemia decreases PTH secretion. That is the story. Now, what is a very common cause why magnesium level decreases? Diarrhea, aminoglycosides, diuretics, alcohol, diarrhea, aminoglycosides, diuretics, alcohol, typically are the causes of hypomagnesemia. Any hypomagnesemia increases the parathyron production. That is what you need to ultimately remember. So quickly tell me, doctor, what is the effect of parathyron on GIT? Before we conclude, yeah.
Increase the calcium and phosphate resorption.
Absorption in GIT, very good. What is the effect on bone resorption of parathyron? Come on.
Cause the reabsorption of the bone.
It increases bone resorption, it increases calcium and phosphate. Now, in which part of the nephron parathyron acts to affect calcium reabsorption? And what is the effect?
DCT. DCT increases calcium resorption.
Good. It acts on DCT and increase calcium reabsorption. What is the effect of it on proximal femoral tissue?
Decreases phosphate reabsorption.
Very good. Then, what is the receptor you find in osteoclast and osteoblast on which parathyron act?
Rank L receptor on osteoblast and osteocyte, and rank receptor on osteoclast.
Very good. And what is the effect of intermittent PTH on the bone and continuous PTH on the bone?
Intermittent PTH, it leads to bone formation. Continuous bone resorption.
Beautiful, beautiful. Then tell me two cancers where PTH related peptide is produced.
Renal cell carcinoma,
Squamous cell carcinoma of lung and renal cell carcinoma. Now quickly tell me, what is the effect on PTH secretion of serum calcium?
increases.
So is it low serum calcium or high serum calcium? Which increases PTH secretion?
Low serum calcium increases the PTH.
Very good. And what is the effect of magnesium?
Decreased magnesium produces increased pH. Severe decrease in
Correct. And very low magnesium?
will decrease PTH.
Decrease PTH. What is the effect of phosphate on PTH? Come on, doctor. Phosphate. High serum phosphate increases PTH secretion. Tell me, what are the 4 causes of hypomagnesemia?
Diarrhea, diuretics, alcohol, and hypomagnesemia.
And aminoglycosides. Very good. So thank you so much for the wonderful time all of you have given. I like to see you every day at evening 6 p.m. Good night and study well.
Thank you, sir. Good night.